So first, an overview of the 2025 update on effective cataract surgical coverage. As Stuart mentioned, cataract remains the leading cause of blindness globally. For the year 2020, it was estimated that 17 million people were blind from cataract. That's about 39% of all blindness worldwide. Cataract is also the second leading cause of moderate and severe vision impairment globally, affecting around a further 83 million people. Recognizing this enormous public health challenge and unmet need of cataract surgery, in May 2021, the World Health Assembly endorsed two key indicators for eye care: effective refractive error coverage and effective cataract surgical coverage, ECSC, and set a target for ECSC of a 30 percentage point increase by the year 2030 from the baseline in around 2020, while paying careful attention to equitable service delivery. In 2020, WHO convened a working group to develop definitions and methodologies for both new indicators. You can read about these in this report published in 2021. ECSC is an effective coverage indicator, which is WHO's preferred approach. It is a population-level indicator that is derived from surveys, and in summary, it's defined as the people in a population with a good visual acuity outcome following cataract surgery as a proportion of those who currently have unoperated cataract, plus those who have previously had cataract surgery. In 2021, WHO also updated the definition for a good surgical outcome from 618 to 612. As mentioned, ECSC is a population-based estimate from survey data. The primary source of data for ECSC is currently the Rapid Assessment of Avoidable Blindness Survey methodology. RAB7 is the latest generation of RAB. Delivered digitally, it enables faster, more accurate collection and analysis of secure, high-quality eye health data relevant to current eye health priorities. It includes an optional module for the collection of additional data around diabetic retinopathy. RAB7 has been developed through a collaboration between the International Centre for Eye Health and Peak Vision in consultation with a steering group made up of representatives from key stakeholders in the global eye health sector. A population-based sample of people is assessed for current cataract or prior surgery. There are three metrics that we typically then calculate in relation to cataract surgery. Firstly, cataract surgical coverage, or CSC, effective cataract surgical coverage, ECSC, and the relative quality gap, RQG. Taking this hypothetical example of 1,000 people, 80 have untreated cataract, that's the red faces, and 40 had cataract surgery previously, that's the blue faces. First, to estimate the cataract surgical coverage, CSC, you divide the number of people who have previously had cataract surgery, irrespective of their outcome, by the number of people operated, plus those with unoperated cataract. So in this example, the CSC is 33%. To estimate the effective cataract surgical coverage, you need to take into consideration the outcome of the surgery. Some operated people will have non-good outcomes. That's defined as visual acuity less than 612. You divide the number of people who have previously had cataract surgery with those who've had a good outcome, that's 612 or better, by the number operated plus those with unoperated cataract. In this example, the ECSC is 23%, down from 33% CSC. The third metric is the relative quality gap. This is the difference between CSC and ECSC as a proportion of CSC. So in this example, the relative quality gap is 30%. The baseline ECSC report, which included data on 55 countries, was published in 2022 and fed into the World Health Organization baseline reports on the indicators. This updated report published today builds on an expanded list of primary data sources. It includes 233 surveys conducted in 68 countries to provide empirical estimates for ECSC at the 6/18 threshold in terms of outcome of vision. estimates of the the relative quality gap, and an analysis of the causes of that gap, and then finally model temporal trends from the year 2000 to 2030. I'd like to draw your attention to the appendix, which is available online, which has a lot of additional detailed material on the methods that surveys use to calculate the data and the results. This figure plots the cataract surgical coverage as blue markers on the right, and the effective cataract surgical coverage, the red markers on the left, for each of the 68 countries. The line between reflects the quality gap between CSC and ECSC. There is a very wide range of values for all three metrics, with ECSC ranging from between 22 and 78%. The regional median ECSC values at the 618 outcome level range between 15% for the Africa region and 45% for the Eastern Mediterranean region. For more recent surveys, we have access to visual acuity data at the 612 threshold, that new updated WHO good outcome level. And as expected, this reduces the ECSC values a little bit across the board. We use data from 120 RAB surveys that analyze vision to the 612 threshold to calculate the overall global and regional median percentage contributions of causes of non-good outcomes. That is, people who have visual acuity of worse than 612 who have previously been operated. Globally, refractive error and ocular comorbidities both accounted for 26% each, intraocular complications for a further 20%, and posterior capsular pacification at the global level, 11%. The median percentage point increase in effective cataract surgical coverage at the 612 level that might be achieved by addressing the residual refractive error following cataract surgery was around 4%. 17 locations had effective cataract surgical coverage data at the 618 threshold from surveys available at time points several years apart. These are shown in this graph. For 9 of these countries, the 95% confidence intervals do not overlap, suggesting a significant increase in effective cataract surgical coverage. The largest percentage point increase is ECSC at 618 for Qatar at 27% between 2009 and 2023. With the exception of Mali and Senegal, there was limited evidence of increasing ECSC at 618 from the African region. As mentioned, we used 228 datasets to model regional and global estimates for ECSC at the 618 level from the period of starting at 2000 up to projecting forward to 2030. These figures show the trend for the individual WHO regions. In the current decade, from 2020 to 2030, the modelled increase in ECSC at the 618 threshold was 4% for the Africa region, 8% for the Americas, 6% for Eastern Mediterranean, almost 14% for Southeast Asia, and 18% for Western Pacific. Currently, there is insufficient data from the European region to be able to model this trend. For the year 2025, the model predicted a global ECSC at the 618 threshold of 48.2%. Between 2000 and 2020, there was an estimated 15.6% increase in ECSC at 618. In the current decade, from 2020 to 2030, we estimate that there's only an 8.4 percentage point increase globally. This is set against the overall target of a 30 percentage point increase for this decade. So in conclusion, globally and regionally, ECSC is increasing much more slowly than the World Health Assembly target of 20 percentage points increases this decade. Action is needed to increase cataract surgery urgently. The relative quality gap remains large in all regions, but addressing post-operative refractive error is both a realistic opportunity to boost effective cataract surgical coverage. And it's really important to report the reasons for non-good outcome to inform programs in terms of how to improve quality of outcomes. I'd like to thank you very much for your attention and joining us today. I'd like to highlight the contributions of four members of the ICH team: Ian McCormack, Emma Archer, Dave McLeod, and Jackie Ramke, who did a lot of the work in doing this analysis. I'd like to also thank the wider authorship group and the ECSC study group, particularly country representatives who've contributed a lot of data to this analysis. And finally, our funders, the Indigo Trust, the Wellcome Trust, and the Fred Hollows Foundation that have supported this work. Thank you very much.